epidemiologist, and she specializes in policy, information systems, and metrics for evaluating health systems, programs, and institutions. Currently, Sally is the director for Deloitte here in Arlington, Virginia, and she works where she works with multiple stakeholders to work on strengthening strategies and systems to improve health outcomes. Sally, Dr. Stansfield has worked extensively in parts of Africa, Asia, Central and South America, and also the Middle East. Before joining Deloitte, she was the founding director of the Health Metrics Network, and she also has worked for the Bill and Melinda Gates Foundation, Management Sciences for Health, International Development Research Center, IDRC, USAID, and also US CDC. Now, we also have Andrew Wyborn. Andrew is an entrepreneurial businessman, and he is the founder and CEO of GreenMash Limited, which is a software and services organization that implements management information systems to support health programs. They've worked in many countries, including Kenya, Ghana, Tanzania, Cameroon, DRC, and South Africa. So I will leave it at that, because I don't want to give everything away already. So what I'll do is I'll ask questions, and I'll just get our panelists to respond, and then after we have a few of this, we have a chance to go through a few of these questions, we'll invite you as the audience members to ask them a few things as well, and also to share your experiences. So the first question is general. It's what do you think the role of mHealth is in national health information systems, and then perhaps to put the scope a little bit more broad in for health systems in general. And I'm going to start with Andrew. Could you share some thoughts with us, please?
Yes. Morning, everybody. Hopefully you can all hear me. What is the microphone working?
Yep.
Good. What is the role of mHealth? Good question. Well, the way we see it, we are, as was during the introduction, I run a software and services company, and the majority of our work is what's called mHealth, mobile health. So we deploy systems that enable people to capture data using mobile devices typically, using whatever information sources are available. So that could be SMS from a very simple Nokia-type handset right through to smart devices collecting information offline. So we can work with whatever technology is available, and typically we're collecting information related to things like essential medicines. So we run a lot of, or support a lot of programs that are designed to bring visibility to essential medicines, anti-malarial medicines and so on, from places that are typically hard to reach. And that really is where I see mHealth providing some real value. mHealth shouldn't be considered as an add-on or a separate, special piece of a health system. It should be considered as the integrated part of a health system. And what it's doing is enabling health or ministries of health to capture information in real time, fast, accurate data in real time that feeds into their central management information systems in a way that they couldn't possibly do before. If you talk about stock data, for instance, coming in from remote health facilities, typically that would be done on a monthly basis, stock sheets filled in on pieces of paper, collected by the district manager, and at some stage keyed into a spreadsheet or into an email, and at some stage gets up to a central repository where someone can look at it and realise that the information is several months out of date and practically useless. Whereas nowadays, with mobile devices, that information can be requested weekly, monthly, fortnightly, daily, even if required, and responses can be almost instantaneous. So what that enables district managers, regional managers, national managers to do is to have a complete real-time view of what's happening across their health system. As I say, mHealth shouldn't be considered as a separate special department over here. It's very much part of a mainstream health system. It replaces old-fashioned paper-based ways of collecting data. And broadening out from mHealth, broadening out from health systems. Once you have an infrastructure in place to support mHealth, you can, if you have a flexible platform such as the one we provide, you can incorporate payments, incentives, rewards out to health workers, which again traditionally would have been, if you were going to pay those, they would have been paid over months or sometimes years or sometimes not even. Just weren't even conceivable. Now, we run some programs or support some programs in some countries where part of the program is to reward people financially for sending in information on time. So if they send information in within a 24-hour period following the request for the information, they get a small amount of airtime credit sent back to them automatically through the system. So you can start to use your mHealth platform to distribute not just information about the health itself, but you can use it to distribute payments. You can bring in motivational messages, which again would have traditionally been quite hard to get out on a real-time basis to the facilities. And it's been shown that motivational messages delivered by text have a real strong impact. There's been various studies published this year. One was by Dan Zurovec, which he did a 6-month program with 2 messages a day going out, and the impact was measurable on the quality of the healthcare that was given at the health facilities for malaria. You can send out motivational messages, awareness messages. So we're getting involved in some countries where there's an eradication program, and people need to be made aware to look out for instances of the disease that's being eradicated. So again, your mHealth program can come into that as well. It doesn't have to be just focused and siloed on one part of the health service.
Good. Yeah, thanks. So just to build on what Andrew's already said, I think some of the points he made were brilliant, and so brilliant, in fact, that I will have to confess he stole several of the things I was going to say.
I was reading your notes.
That's him! But there's no question that information is the nervous system of the health system. So if our health system is going to work, it's going to be because we've wired it with the appropriate information, technologies, and services to really make it spin, make it work. Andrew referred to incentives, and rewards, and payments, and there's also accountability, reporting, surveillance. Without these information functions, none of the components of the health system are going to work. So I think we just need to make that the first given, that until we get the information system right, we don't really have a health system. But the power of mobile to enhance the reach and agility of the health system is immense. I think one of the big mistakes we've made to date often is we've failed to really understand the value add of the mobility, and to really focus the mobile applications on things that are clearly targeted to tap that value add, to exploit that value add. The implications are immense for functions like surveillance, for accountability, for transparency, for really just making the system work. And just to finish, because we want to keep the dialogue moving, but I think perhaps the most exciting transformation that mobility can offer for the health system is making it more person-centered. If we can use mobile devices, mobile applications to really put more power, more control, more responsibility in the hands of the people whose health is to be improved, I think that will finally deliver on the promise of mHealth for improving health outcomes.
Thank you. I will make a very quick addition to those comments because they were very thorough and helpful. We all have talked about during the course of the conference the fact that mHealth is a part of eHealth and it's a part of information systems. But there's a reason why we have an mHealth conference, why we're specifically here to talk about it. And while it is a component and an integrated part of these other systems, it changes everything about those systems. And so the fact that it improves data collection, accelerates data collection, it improves important mechanisms like supply chain management for pharmaceutical. Getting that last mile has the same impact for health that, for instance, mobile finance has for the unbanked. And so it has transformed the discussion. We also talk a lot about health information systems in our firm. And it's important to remember that health information systems are first about information, first and foremost. And then some of them have technology involved and some of them don't, especially in the developing world. But understanding and getting that piece of it right and then plugging in the technology, including mobile, is really important to keep in mind.
Great. Thank you very much. So we got a lot of nice background responses. So looking at mHealth as a means to capture real time, its capacity for its reach and being agile, and perhaps to improve accountability and transparency and person-centered, and looking at the last mile, which I think some also call the first mile, in terms of the importance to engage the end user. So here we're talking about organizational and country capacity. Now, given what you've just told me and everybody about what the role of mHealth can be within health systems, can you give me a sense of what your experiences have been in terms of working with in-country organizations and institutions and individuals who are the ones who are using these systems and hopefully taking the leadership role in implementing, designing them? What your experiences have been in terms of what these types of capacity strengthening approaches have been. This time we'll start with Brooke.
We've been working with a couple of important initiatives that have been discussed here a lot at the conference. One of them is MAMA, the Mobile Alliance for Maternal Action, sponsored by USAID, Johnson & Johnson, UN Foundation, a number of partners. And we did some work with them in the last year on their capacity building strategies. And what we found for mHealth providers, and I think we can extend this into national level mHealth providers as well, a lot of their need circles around content creation. It revolves, interestingly and simply, around the ability to procure the kinds of professional services they need to fill the gaps within their organization. And it may sound simple, but it's not quite as straightforward as you might think. So just being able to put together the complete team and professional capabilities that are needed to develop, scale, and sustain an organization. And then also around monitoring and evaluation, not just M&E, but actually applying that M&E to improving one's own performance. We're working right now with the Ministry of Health in Nigeria on one of their maternal and child health programs, actually developing a performance tracking system and a dashboard and training them on how to take this great data and use it to improve the way that they're performing. So these are some great examples from the field that we're seeing of areas where capacity building has been very beneficial.
Yeah, cool. I just want to underline Brooke's point about the procurement of products and services. I do think that is that's a really important thing, and just helping. I think one of the big challenges for developing countries, particularly where donors will often push a specific product or service or gadget, the onus is really on the developing country leadership, national leadership, to make good choices. And sometimes I think they get pressed, dare I say, into doing deals with specific vendors or specific widgets that are not really good for their system. So the more we can as a community make a commitment to make sure that folks make good choices, I think it will reflect well on mHealth as as an intervention, if we help countries make good choices. I would just also point out, one of the things we did when I was at WHO and the Health Metrics Network was worked with 89 countries to really reflect upon their information system, their sort of approaches to eHealth and mHealth. And so countries are, without question, working on this. They probably have more of a strategy, more of an approach, a more well-considered approach to mHealth than we do in the overdeveloped world. So I think the industrialized world needs to recognize that we're being left in the dust, for the most part, by the developing world. There are several reasons for that, including that they have fewer legacy systems. They have less of the feeding frenzy of vendors and gadgets to deal with, which kind of leaves them open to making smarter choices. And I'm trying to be a little provocative so that we'll have a really nasty discussion afterwards. But I think the other exciting thing is that, and we've heard references already to the importance and the potential, the massive potential for integration. These countries are committed to a much larger extent than industrialized countries are to integrating into a really comprehensive system. So I think they will be in a position to document that better information does deliver better health outcomes as well as efficiencies. And so we will look to developing country leadership to really make the case for mHealth.
Excellent points, and probably haven't got much to add on that, other than as a technology provider, our role is to gather and make data available to enable people to make decisions. And from a capacity point of view, I guess part of our role is to work with the in-country guys to understand exactly what the requirements are, and then make the data available in a way that it's easy to use, it's easy to understand, easy to use, and hard not to use. And I've got an example of a program. I won't name the country because it'd be embarrassing, but there is a program that collects data on a weekly basis, very high response rates, 80% or more of the recipients of the messages respond every week, and you're talking about thousands of recipients. The data comes in every week, it shows stock out position every week, and nothing happens. No one does anything with the data. So, so just having the data itself isn't a cure-all. So what we're doing now is looking at the data and saying, well, why isn't it being used? And what do we need to do in order to get it to be used? So it's about working with the guys in country and increasing our capacity as much as their capacity to say, okay, well, we now know with the technology will enable us to capture the data. We now need to learn with each other how to make the data or get the data to the right people at the right time in such a way as that they want to use it, they're motivated to use it. It's hard to avoid using it. You declutter it as much as possible, and you reward the people that do use it, and perhaps introduce measures to people that don't use it. So from a capacity point of view, it's all about making sense of the data that you're getting.
Okay, thank you. Now, I've been very quiet, and I've let the first two rounds go in a very nice way, but I also want to be a little bit provocative, and I hope the panelists will excuse me if in the next round, if I do interject from time to time to just pick up on a few things. So I'm going to go a little bit off script, because we did have a little bit of a script, and there are a few There are a few things that were brought up, which I thought were interesting. Sally was mentioning that developing country decision makers are sometimes rather pressed to make choices, and what does that mean in terms of the choices that they're left with, in terms of the systems that are in place? being able to maintain the systems, being able to modify the systems, being able to govern the systems for themselves. So when we hear about mHealth, we often hear about the capacity to gather data quickly, to gather it from more people, the reach that it has. Now, does more data mean better data? Does more data faster and from more sources necessarily mean data is going to be used, that it's going to be trusted? Now, I'm going to ask the panelists what their experiences are in terms of working with ministries of health, working with different institutions who are implementing these systems, who are using the systems, what their experiences are. And I'm going to ask you for a negative experience about when you've gone in country. They're really going to get mad at me after this session. After you've gone in country and you expected something to happen, but perhaps that issue of underlying trust and use of data from systems that are in place didn't quite work out the way you wanted it to, and perhaps if you've learned something from that. Andrew looks like he's chomping at the bit, so please.
Well, the example I just gave was probably an example of that, where you expect that you deliver regular, weekly, accurate data in real time to people who should be interested, to move stock around, to alleviate stock outs, and it doesn't happen. That can be a bit of a shocker and make you wonder, why that data is not being used, and there could be a whole variety of reasons. It could be that maybe the program itself wasn't integrated appropriately at the right levels within the Ministry of Health, because ownership, if you just go and impose a program on somebody, why should they use it? It's not their program, it's your program. So it just shows that when you put any kind of system in, you've got to engage with all the stakeholders, because if you don't, that's a classic reason why people won't use the data. You've got to explain what the data is for and how it should be used. So training, if you don't implement the training correctly, that can create real issues. And also, you can, as we were just saying, you can over-data people. You can overload them with data. So, in that particular program, the district managers were receiving updates on every single facility in their district with all the stock levels for all individual items. And it required them to do a fair amount of work to go through each line of data and work out, who was understocked, who was overstocked. Whereas the approach we're taking now is we're just pushing the key essential data to the district managers to say, look, don't worry, everything's fine, apart from this guy's running out of stock and he's approaching his minimum level. Maybe you should do something about that. So he's only got one thing to think about, and rather than relying on that person, that district manager, to log on to a system to find the data, we can push the data to him through either a text message or through an email. So he doesn't have to do anything other than read his email and take the action. So, it's all about it's learning from the mistakes. Got another one for you as well. I've got lots of mistakes to talk about, but because I'm 50 and I've made a lot. But we ran a really successful pilot last year in Kenya, which is well documented, and if anyone wants a copy of the evaluation report, I'm more than happy to share it with you. The very successful element of the pilot was on stock reporting. We saw almost stock reporting. Sorry, we saw almost an immediate impact on the level of stock outs. I mean, in Kenya, after about 6 weeks or so of running the program, in the 5 target districts that were operating the program, they totally eliminated total stock out. So they still had some stock outs of individual items, but an overall total stock out was totally eliminated. And throughout the whole 6-month pilot period, that was maintained, and the overall stock out level came down as well. And we applied the exact same process of gathering data to surveillance indicators as well. So on one day they'd report on stock, and another day they'd report on surveillance. And the surveillance indicators they're reporting on were outpatient visits, number of those outpatients who were tested for malaria, how many of those were tested positive, and how many were treated. And we assumed that the response rates would be as high, which they were, up in the sort of 80–90%. And we assumed that the accuracy rates on the evaluation would be just as high, which high 80%. But on the stock, while they were very high, on the surveillance they were very low. around the 50% mark, and it was because the way of collecting the data that had been built into the program was just too complicated. You're talking about overworked health facility workers who have been asked to collect quite complicated data from more than one ledger, having to go back to a particular point in the previous week and then work out how many people had been through tested and how many had been tested with remote diagnostic test kits and how many had been into the lab. And it was just too complicated to get accurate, meaningful data from. So the lesson learned from that is that it's probably too much to ask them to report on a weekly basis. And so in Kenya, they've decided to switch to monthly. And it's also too complicated to work from a variety of ledgers. So they've now introduced new ledgers so they can capture all the information in a single place.
Perfect. I'm going to stop you there if that's okay.
Sorry,
Okay.
I've got loads more.
I know you do. We'll come back to you. Thanks, Andrew.
Sorry.
Okay. Couple to add. There's no question, though, that there are both good stories and bad stories, that sometimes the data that people are asked to relay electronically or report through paper-based systems, may introduce either positive incentives or perverse incentives. So there are plenty of examples of each. I think my favorite, because it's been both mobile as well as paper-based systems, and is very relevant to the MAMA work. But there are growing numbers of examples from many countries. I know that Bangladesh, Ghana, Sierra Leone. We can list lots of countries that have very successfully, by holding community health workers or midwives accountable for their referral patterns, they have dramatically increased the proportion of deliveries that are facility-based. And while we haven't documented that indeed leads to reduced mortality, maternal mortality, it undoubtedly does. You can make a credible argument that this has saved lives, and there are several, at least anecdotal examples that are very powerful. So there's a good news one. My favorite bad news one is, although it was not an electronically relayed bit of data, but watching a growth monitoring clinic one time in a country that shall remain unnamed, they were, kind of putting kids into the slings and, checking the weights and documenting them and doing a damned good job of counseling the mothers and, telling them about the child's growth pattern. And until I noticed that there was this little gaggle of children in the back looking really bad, all the classic signs of malnutrition, sort of the bad hair, big bellies, just really children not thriving. Very tragic-looking kids. And I said, well, what about these? Are we going to measure their weights? They said, oh, no, Dr. Stansfield. This is a growth monitoring clinic. Those children are not growing. So one does need to be careful about, when you kind of get people jazzed about why they're collecting data, to kind of not inadvertently introduce biases as to what people collect.
To your question, Shadley, about is there such a thing as too much data, I think there can be a lot, there can be a little, but data is only as good as the intelligence that you can extract from it. And so with the incredible amounts of data around the world amassing, and especially in the developing world through the use of mobile phones, there is a whole new level of intelligence extraction that has to go on through largely big data, what's now being termed big data, which is simply the analysis of data that's just too big to even fit on a normal data center type of platform. And so having the types of data scientists that can actually pick the right metrics to be tracked and extract that information from huge amounts of information, huge amounts of data, is key. So I think I would offer a different question, which is not is there too much data, but is there the right process to figure out what you're trying to extract from it. And it can also be, on the other end, extracting information from smaller bits of data, or being very selective about what it is you're trying to measure can can be extremely effective as well. I just wanted to make one other related comment, if I can, that especially in countries that are very aid-rich, there is an overload of data collection requirement because each donor has their own set of metrics that they need to have reported on in compliance with their grant. And this brings up a need and an activity that's actively being addressed by the donor community to align their requirements across their grants to help minimize the number of metrics that have to be looked at by especially government programs. Otherwise, they spend an inordinate amount of their time collecting data just to comply with the donor grant requirements, as opposed to actually using the data to improve their work, which was the original intention of the M&E requirements in the first place.
Okay, great. Lots of provocative and interesting points made there. I'm going to draw out what I see as kind of an overarching theme that might be thread together some of those things and ask you guys a question based on that. Don't look at your scripts. And that theme is the theme of ownership, because whether it's big data, whether it is mainstreaming mHealth into national health policy, whether it's ownership of code bases that mHealth is written on, whether it's ownership of the indicators and having a say in how those are shaped and streamlined and done like that. I'm going to be asking you a question about ownership and about, but not so abstract. Specifically, I'm going to ask you about your experiences and even perhaps your ideas for the future of how different countries are managing this issue and kind of coming together, be it as stakeholder groups. There are different eHealth, mHealth, health information systems working groups that we see in different countries that work across different ministries, that work across civil society, private sector, etc., to make sure that there's an understanding of what the needs are across these sectors and across these needs in the country, to then kind of speak with some kind of common voice to then influence how that ownership dialogue, negotiation, discussion might take place. So I'm going to throw that back to the three of you, and you can choose who wants to answer first.
I think Sally should start.
I think Sally should start too.
Oh, nice. Well, I guess one of the fundamental principles of information, data, is that the stuff you love best is the stuff you collected, or at least decided to collect. Nobody, you can be overloaded with data, and it's everywhere. But until you ask the question, you really don't care about the answer. So the issue of ownership, I think, is really important. So I think, and the key thing is probably not so much about owning the system that generates the information as it is making sure that people really own the sense of need. They own the questions. They own the drivers to get the information and to make the system evidence-driven. And I think some of the things, including what Brooke is talking about with the donors really trying to let go of their stranglehold on the evidence is really going to be important, because it costs money to collect it, and a lot of the data that we love best is still owned really by donors. So, I mean, our IDRC, for example.
Everything that is done is owned by the researchers, and everything's made available on our open access database. So.
IDRC is entirely wired about, and it used to be empowerment through knowledge. I mean, essentially, owning your facts becomes the basis for ownership of the problems, ownership of the solutions, and ownership of the accountability for delivering on those solutions and better outcomes.
I'll just make a quick comment in terms of how to frame, in the way we frame and think about the question, because this question is coming up increasingly about ownership of data as we look at especially topics like big data. And I think some of the nuances that need to be thought about, there's data attributed to the individual. So if there's data attributed to my name, I actually kind of want to own that data, right? But then there's, anonymized data, and should that belong to the collector of that data? Should that belong to the person, to, I don't know, the national system on which it resides, is a question I think that needs to be sorted through. And then I think more importantly, there's a distinction that is helpful when thinking about this problem, which is there's the data and then there's the intelligence extracted from the data. So I think having access to data doesn't mean you necessarily own that data, but if you're extracting intelligence from it and establishing new facts based on that data, then there's another level of ownership that can be discussed. So I think that's just sort of a helpful way to think about it. There isn't an answer yet today about data ownership, really. It's in hot debate currently.
Again, I think most of the key points have been made. I mean, from our point of view, as a technology provider, our starting point is always that, that we don't own the data. We're just putting the technology in place to enable the data to be captured and analysed. And from my own personal point of view, I always assume that the data is going to belong to the Ministry of Health, and we certainly make it easy for them to get that data, and they can then analyse it in our systems, or we can use our open programming application interface to push it into other systems if required, data warehouses or whatever. We make it very easy for them to extract out to Excel or CSV files or whatever other format they want. So, say from our position as a technology provider, we see our role is providing the technology configured in an appropriate way to support whatever the program needs are, and keeping it working 365 days a year, 24 hours a day. And we make no claims over ownership of the data.
I'm going to ask one more question. Sally, was there something else you want to add?
Yeah, if I can just add something to this issue. I think one of the health is peculiar in terms of ownership, and I think one thing that is a bit of a cancer in our current system is the fact that healthcare providers and institutions, facilities, view health data about individuals as proprietary. They use it to basically extract loyalty from patients and therefore assure their future revenue streams. I made reference earlier to, I think, what will be a coming revolution that will be facilitated by mHealth applications. But the more we can push ownership to people, the more we will be able to make it the norm that the big data, the extracting, reading patterns from individual health records, can deliver public health intelligence, surveillance information that will finally save all of our lives for the future. Because, if thinking about this fungal meningitis outbreak in the U.S., for example, the data about the incidence of headache and meningitis-like symptoms associated with use of a specific procedure and product should have made that thing evident, that outbreak evident, weeks or months earlier, and it would have saved a lot of lives. So the data are there. We need to we need to rethink the ownership issues in order to be able to deliver better health outcomes.
Great. And I'm going to ask one last question, and then I really want to open it up to all of you to ask your questions. My last question is, when thinking about mHealth, we tend to think that it automatically will reach those that are unreached or those that are the most vulnerable, but that's not always the case. In terms of being able to detect patterns and outbreaks and things like that, how can we ensure that mHealth is distributed, used in ways to actually improve equity in terms of those who need to access services, who have demands that are perhaps not known about right now and unmet. So that's one part of the, it's a little bit more abstract, and I'll leave it up to you to answer it how you'd like. The more concrete part of the question is, what is your sense of, when we talk about mHealth being mainstreamed into national health systems, as mHealth is getting more and more scaled up, which is something that we know there's a need to scale up from the pilots to larger scale interventions or systems, how do you see mHealth as being mainstreamed as a way to strengthen integration within health systems rather than create massive silos of scaled up, really sexy, works well mHealth solutions? So that's the concrete part. Where do you think the country capacity, the institutions, the organizations, the policies, et cetera, can perhaps help to make sure that mainstreaming of mHealth, A, is done in a way that can redress inequities that are there and can strengthen the systems rather than fragmenting them further with deeper silos?
Okay, well, I'll take the second question first. That's the easy one. Well, I guess a lot of the so-called silos come about through. If you look back at how some of those programs started, they were introduced by donors wanting to address issues with a particular disease. So they look at okay, we want to expand our activities to find out what's going on with malaria in this country, and so the program will be devised. A technology company or a technology organisation will be included as part of the consortium to address the issue, and lo and behold, you've got a system that's focused on malaria, and in another part of the country, another donor will be looking at prevalence of HIV/AIDS, and the team that addresses that issue will build a system to address HIV/AIDS, and that's how you get silos developing. And again, without being too provocative, I mean, in some instances, it's not a problem. I mean, why would the AIDS people want to know what's going on in malaria? I mean, that's just the way it is. But technology nowadays, if it's the right technology and the thought is there, there's no reason why relevant data can't be shared across, even if you do have multiple systems in multiple silos. There are relatively straightforward ways of sharing data using interfaces and web services, even at some stage interoperability standards. It's not technically a major issue if the technology is right to share data. Obviously, in the ideal world, excuse me, in the ideal world, every country would select one data gathering platform, one MIS system, and that MIS system would be used for everything, and then it's not an issue. But that's in reality that probably is unlikely to happen. I would have thought. Just touched on a point there about pilots, and it's interesting because I've heard over the last 2 or 3 days people use this phrase pilotitis, almost in a way that all pilots are bad. And again, without wishing to be too provocative, I don't think that's necessarily true. I think there's good pilots and bad pilots. I mean, the idea of a pilot is you test something out, and if it works, then you scale it up. A bad pilot is one where there's no intention of scaling, and there's no, it's just there in a limited geographical area, or it's only ever going to be focused on one disease area. But the idea of pilots being bad and scale up being good, is a bit too broad, a bit too simplistic. Yeah. Avoided the first question.
Well done. Poorly disguised evasive maneuvers. That's good. I like it. Just to touch upon the sort of equity implications of mHealth, I mean, I think we need to get over it. New interventions often are tapped first by the more privileged, by the more educated. If you look at the data on mobile, it's had, as we all know, a stunning ability to reach the least, the most impoverished populations. So it works. I just think we need to let that one go, because the one thing that we can do is make sure that the nations put smart policies in place, working with their telecommunications industry, working with their health ministries, put in smart policies so that you can reduce the cost barriers to using the life-saving mobile health interventions, and that's easy enough to do, and people are getting clever about that. I think that will work. And then in terms of the mHealth as it can be either a fragmenting or an integrating force. We've seen, because of the sort of bright, shiny, bobbly things that are those lovely apps, they can be very fragmenting. But mHealth, I think, could be a real force for integration, particularly if we pay attention to how mobile devices could be used to provide access to personal health records at different facilities. For example, if each facility you went to could be given instant access to your health record by calling down that access over a mobile device with a PIN, then I think mobile devices could become a real force for portability and for universal coverage with health, with the life-saving health interventions. So I think that's completely doable. We need to make sure, as a mHealth community, that we make these things happen.
All right, well, we'll just talk over
It's a message from God.
Yeah. Brooke, please.
I'm scared.
Yeah. Can you guys whistle?
I got it.
I follow directions sometimes.
I think things are a little too interoperable.
Maybe.
Yeah.
Should I wait or should I talk?
If
I talk,
I think
is
we
it-
should. Yeah, I think
is
you
it-
should talk because
Okay.
I want to give people a.
You're not going to be all confused?
And can you make it?
We're done. Really short.
Yeah.
Oh, yeah, okay. I just have 3 letters. MNCs, multinational corporations.
Okay.
So I think it's one of the things that has been talked about very little in the conference, and I talk about a lot in rather lively debates, having come from that world, from Hewlett-Packard. When we figure out what a good national level health information system is going to look like, and it's well integrated with mHealth and everything else that's required to be successful, I personally believe the fastest path to making that ubiquitous around the world, especially the developing world, is to engage multinational corporations that excel at making solutions like this go global really fast.
Yep.
Okay, so I'm not going to sum that up because I want to give you guys time to ask questions, but we have very different and interesting perspectives represented on the panel, and I'm going to open it up to questions. Please introduce yourself.
Hello,
Merrick.
Merrick Schaefer, the World Bank. After listening to this panel, I feel like the issue that the panel's actually on was danced around. It was touched upon slightly, but it was not addressed. It was not addressed head on at all. And I thought that was a little surprising, and it made me reflect on potentially we don't know how to create or increase organizational capacity, especially in ministries of health. And I think it's interesting that like Tanzania, Rwanda are not here talking about their reflections on how to increase their capacity in here. And I also think that there's things were touched upon. Regulation, yes, but what regulation? How do you create an enabling environment? mHealth technical working groups that span ministries, yeah, exactly, but what is the point of those? What are you trying to drive with those? Like, how do you actually shift ownership from the donors and from the NGOs to the government to take these projects on? Is that even the right thing? So maybe I'd like to hear a little reflection around that challenge, and maybe like, do we actually not know how to do this yet?
Good provocative question.
Want to
Why don't we answer that one, and then we'll wait for others. Yeah.
Okay, great. I'll just give a quick example of the work we've been doing in Ethiopia, where the Ministry of Health has can you hear me okay?
Yes.
Sorry. Ethiopia, work we've been doing with the Ministry of Health. Their IT department consists of one 25-year-old who is meant to, figure out how to embrace the recommendations we've been making about how technology can improve, especially mobiles can improve, the efficiency of their health extension workers and their pharmaceutical supply chain, et cetera. They were ecstatic to see us there. And so, Merrick, I think in situations like that, the answer is bringing in the support that's needed, at least initially, until they can build up their own internal IT systems or personnel to take it on. And whether or not that's available locally is, a multidimensional question regarding education systems and funding and time to be able to integrate those systems into the way they operate as an organization. And until then, there are fantastic local and international resources to help them do it for them.
Yeah. I'll just make one little comment on that, because I think you're right. We kind of ducked that issue in the panel. Let's try that. Good. But, there is a lot known about institutional capacity building. There are lots of sort of tools and approaches to make it happen. It's not always easy. It's tough to build the capacity of an institution in a framework that is not going to be conducive to strong performance of that institution. So it's really less sometimes an individual institution than it is the society's constellation of institutional forces that all need to work together. mHealth is not going to be something that can be achieved by a strong Ministry of Health. You need telecommunications, you need business, it's not a single institution. So I'd say we need to go beyond institutional capacity building to, making sure that the society has a constellation of institutional forces and societal stakeholders to make this work. So just to raise the level of difficulty even beyond institutional capacity building.
Did you want to comment on this?
Well, only from a technology point of view. Obviously, we're a technology company, and in the ideal world, we would be handing our technology over and training people how to develop it themselves. But we don't really do that too much. I mean, we do offer the option to local developers to create open source modules to add functionality to the platform. To date, we haven't had anyone take us up on that offer, and the problem that we see is that the talent pool in a lot of countries is relatively small compared to the size of the country, and quite frankly, the cream of the talent isn't sitting in the public health service; it's sitting in the telcos and the big corporations.
Okay, let's take two more questions, one after the other. Please, in the front first, and then.
Hi, I'm Willow Gerber from MSH, and I want to thank you for all of you on the panel. I agree there's lots to be said around organizational development, but I also want to say to the gentleman from the World Bank, the fact that the World Bank is turning over all their data now. 10 years ago, who would have thought? And so one of the things I wanted to bring up is issues around pre-service, and you talk about a single 25-year-old. And what are we doing at the pre-service level so that the folks coming out of medical school or public health schools are really paying attention to this as a game changer? And also, what are the incentives to make sure that some of the cream of the crop are really buying into the importance of a strong health system that they could support in a country that is really bound to make huge leaps? And recognizing in many ways that mHealth is really a young person's game, and that we need to kind of get out of these young people's way. I'm always impressed by how young people are far more transparent, and they're willing to do things differently. And so for those of us who have been at this a while, maybe we need some reverse mentoring.
Please, the next question.
Yes. Hi, I'm Sam. I'm from NTT Data. It's like the AT&T of Japan. A lot of them don't know about my company, but we're pretty big in the Asia Pacific and European markets and the African markets. We have noticed that there was a sense of this mobile penetration that was talked about, and the panel agreed that it's very penetrative. There's no question about that. But in this whole conference, during the course of all these 3 days, it's about the smartphone and the smart technologies. Some of these countries that we have worked in, where we need real care interventions and stuff like that, the only access they have is a dumb phone. What you can do, there are constraints in terms of bandwidth. There are constraints in terms of connectivity, infrastructure that was brought about. So when we are talking about defining the IT roadmap or the mHealth solution platform in collaboration with the government there, are we actually trying to address the problems in a manner, especially technologically, not only centric to the smartphones, but understanding that there could be challenges in there and devising some sort of a hybridized solution mechanism which will address care coordination problems that exist in these developing countries.
Okay, thank you. I'm going to ask each of the panelists if they could to maybe choose one of the two to respond to, and then I'm going to close up with some remarks.
Thank you for your last question, and I wanted to respond to that one, and it also sort of ties back to Merrick's question earlier. Another area of capacity building that the governments would really benefit from and mHealth providers in general, is learning how, for instance, to negotiate with the mobile network providers. So you've got network coverage issues, whether it's reliability or it's broadband. So being able to negotiate at that level with those organizations is a really key skill to making sure that services like mHealth can be reliable. And that ties back to one of the comments I made earlier on and further answers Merrick's comment, which is that part of the capacity building that we've identified as necessary for mHealth providers, be it in governments or elsewhere, is around their ability to procure professional services. So whether or not their long-term goal in governments is to have those capabilities be resident in their organizations, in the near term, a stopgap is to train their existing people to procure the capabilities and skills that they need and manage them effectively, so that they get what they needed in a kind of hub and spoke type of model.
I can just say, well, we're passing the microphone. I think the reverse mentoring thing is a good idea.
Andrew, any comments?
Well, only again from a technology point of view. You know, if in a country you use what's available, and if there's good bandwidth and good internet access, then great. You don't need so much SMS flying around. If you're operating in a low resourced area where the only thing is SMS, then we use that, and we take a hybrid approach to capturing data and sharing data.
Great. Okay, well, I'm going to sum up by, first of all, thanking all of you for coming, by thanking the panelists. I think this panel was focused on, what it is in terms of country capacities and organizations to help mainstream mHealth into health systems. And I think the panelists have spoken from their own perspectives and given their own ideas about how this can be done. And I think from my perspective, if I can take my hat off as a moderator for a minute, I think the point is that things cannot be done for other people. As Sally mentioned, what you gather is always seen as the best and the information that you trust most. So there's something about not doing things, and what are the strategies to really deepen capacity strengthening approaches, and really learning from other countries, neighboring ones that have had successful strategies, that have had successful working groups, that have had successful policies, etc. And I think those kinds of intra-regional networks are also very important, and I think it also touches upon what the panelists have also been saying. So I'm going to end by saying thank you again for coming, and thank you the panelists for being good sports, for not knowing really what I was going to ask them next, and wishing you all a great rest of the summit. Thanks.